Welcome everybody to the 5th Migraine Masterclass sponsored by our partners Pfizer and hosted by the IVPN NeuroPsychiatry division of IVPN and in collaboration with the Association of Migraine Disorders. Today is our 5th Migraine Masterclass. If you have been joining us since the beginning, you will for sure know that this is a very valuable series of events that is hosting experts from all around the world to talk about migraine and different ways to approach migraine treatment, the science of migraine, and getting to know the experts of migraine around the world. It gives me great pleasure today to welcome Dr. Dina Kuruvilla, who is joining us from Connecticut in the USA. And Dr. Dina is a very well-known member of the migraine community. She is a board-certified neurologist and a headache specialist, and currently the director of Westport Headache Institute in Westport, Connecticut. She has served as the program director for the Headache Fellowship at the Yale University School of Medicine and is currently the chair of the Women's Health Special Interest Section for the American Headache Society. She has authored original research in JAMA neurology, pain medicine, cephalgia, and headache. Dr. Kuruvilla, it gives us great pleasure to have you here today, and the floor is yours. You're going to be talking to us about patient-reported outcome measures and what they mean for or understanding them for headache trials and clinical practice. Thank you very much for joining us today.
Thank you so much for having me here with you today. It's such a great opportunity to meet so many people from around the world today and to talk a little bit about headache disorders, migraine, and also talk about some patient-reported outcome measures today. I'm Dina Kuruvilla. Thank you so much for the introduction. I know that sometimes after a presentation or beyond a presentation, questions come up or commentary about the presentation. I've included my email on the first slide and the last slide in case anybody wants to discuss the presentation further. So here are some of my disclosures, some of which may be relevant to today's conversation. So today's learning objectives include a couple of different things. I wanted to start off the presentation by introducing headache disorders and migraine specifically, talking a little bit about how we diagnose these conditions and use those diagnoses in our clinical practice. The second thing we'll do is we'll review the different criteria that's necessary to provide the patient with an accurate diagnosis and the right treatment options. And then we'll also highlight what are really the meaningful outcome measures that we have for migraine research. The landscape of migraine research has changed so much over the past 20 years. And over time, the different outcomes that we use in each clinical trial have been so different. And there's been such a large variety. So we'll discuss a little bit of that variety today. We'll also look at, in addition to research, we'll look at some clinical outcomes that may be relevant to you as you're seeing these patients in your clinical practice, different markers that you may be able to follow so that you can accurately diagnose the patient and also treat the patient effectively. And we'll also end the talk today with a little bit about patient preferences. What do patients want out of our encounters, and what do they want out of their interaction when they talk about their headache disorder with their provider? So to start off today, the most common headache disorder that I definitely see in my clinic And, certainly the most common headache disorder here in the United States is migraine. I would even take it one step further to say that I personally think that a lot of the people that we diagnose with other conditions, such as tension type headache, just as an example, or the really common one that people kind of diagnose themselves with, sinus headache, I think these people truly probably have migraine. And I really do think it's the most common headache disorder. And this is by far 90% of the 90 to 95% of the headache disorders that I see in my clinic. A lot of the data that we have in the literature about patient-reported outcomes specifically refers to migraine. So that's another reason why we'll focus a lot on migraine today. We don't have as much data about patient-reported outcomes in other headache disorders, such as cluster headache, tension type headache, many of the trigeminal autonomic cephalalgias or trigeminal neuralgia, for example. So that's a big part of why we'll focus on migraine today. And hopefully, as the research about outcomes evolves over time related to migraine, we'll have more patient-reported outcomes for other conditions, facial pain syndromes, and other headache disorders. But to start off here, we know that migraine is an inherited disorder that's characterized by it's a neurological disease that has a sensory component, autonomic component in many cases, a vestibular component in some cases, cognitive changes, and gastrointestinal symptoms. I tell a lot of my patients that the genetic component really trumps everything when it comes to a migraine diagnosis and the likelihood of somebody having migraine, in addition to environmental factors and lifestyle factors. But really, the genetics trumps a lot when it comes to migraine disease. We know that in 2016, the Global Burden of Disease Analysis reported that migraine is the second leading cause of years lived with disability. And so this is pretty much what I see in patients who come through my office also. This is such a burdensome disease, and it's a disease that carries so much disability when it comes to it disrupting one's personal life, professional life, and interpersonal relationships with other people. We know there's around 1 billion people with migraine worldwide. 1 in 5 women may experience migraine, and 1 in 16 men, and 1 in 11 children experience migraine. And so, being that this is a disease that affects so many people, and such a variety of people, regardless of age, race, whatever it may be, we really need to come up with better outcome measures as we move forward in scientific research. So women are by far most commonly affected by migraine, and this is just a chart breakdown of the ages and prevalence that we see people affected. Certainly, I see people of all of these ages, but certainly we see that the biggest peaks in migraine prevalence are women of childbearing age and women who may be going through the perimenopausal or postmenopausal period as estrogen fluctuation is going on. So it's really interesting. I think that research may also evolve moving forward, specifically looking at outcomes in women who are affected in the perimenopausal period specifically and during the childbearing years. Today's outcome measures that we're going to be talking about are very non-specific for the general population, regardless of race, gender. So it'd be nice to have more outcome measures moving forward that are really targeted to women in these age groups. This is kind of the guide that I use in my clinic when I'm diagnosing people with headache disorders. And this is the guide that I often show to students and fellows and residents just to confirm that we've reached the right diagnosis when it comes to a specific headache condition. The International Classification of Headache Disorders was last revised in 2013. And basically has the definitions for a variety of headache disorders, and also special highlighted excerpts for specific treatments that may be very specific to a headache condition. So I find this very helpful. The International Classification of Headache Disorders is available online in a PDF format and also in a non-PDF format, just by Googling International Classification of Headache Disorders. And I also find that this is very helpful when talking to my patients about a diagnosis. Sometimes patients don't believe when I discuss a migraine diagnosis with them. And so sometimes I'll open this up and show them, this is A, B, C, D, E, F of what you may have. And it makes the patient really trust the diagnosis and the process much more. And so I just pulled out a couple of different definitions from the International Classification of Headache Disorders here. The first one here is migraine without aura. And we know that this is a recurrent headache disorder that usually lasts from 4 to 72 hours. And in most people, the pain is unilateral, side switching, may be of pulsating quality. And these are the specific criteria, and also that the pain should be moderate or severe in intensity, and it can have worsening on exertion and be associated with nausea and or vomiting, or photophobia and phonophobia. And so this is the typical criteria that I use to diagnose patients who have migraine without aura, as long as I've ruled out other secondary causes for headache. When I'm seeing a headache patient for the first time, I do make sure that I rule out other secondary causes for headache before I land on one of these primary headache diagnoses. And these definitions for migraine that I'm reviewing right now are directly from the International Classification of Headache Disorders. And these are the definitions that are used in migraine clinical trials, in our treatment trials. The standardization of these definitions have given us such a higher quality of clinical trial participants, because we make sure in many of the clinical trials now that participants meet these exact criteria before they're enrolled. And in most cases, in larger randomized placebo-controlled trials, patients have to go through anywhere from a 6 to 8 week screening period and document diary data that specifically fulfill this International Classification of Headache Disorders criteria. And so not only does it have use in clinical practice, it also has a lot of use in the standardization of patients that we're including in these migraine treatment trials. It's such an important, this is such an important document. And I also included a definition here for chronic migraine, because these patients can be more difficult to diagnose. And in many cases, when we ask a patient in clinical practice, how many headache days are you having a month, they often only report the most severe days. So now I've kind of had to change my questioning in clinical practice and also in research. And I've had to ask patients, how many days in a month do you have no discomfort in your head or your neck? And when I ask that question a little bit differently, they include those milder pain days in addition to those moderate and severe pain days. So I'm able to capture a more realistic view of what the total number of headache days is. So for people with chronic migraine, make up around 2 to 4 million people in the United States. This is a headache that's occurring on 15 or more days a month for more than 3 months. And it should, these headaches over this period should be of a migrainous quality on at least 8 days per month. And so this is a very common thing that I see in clinical practice. Certainly as a headache specialist, I do tend to see more of the more intractable patients, but I really do think chronic migraine is much more prevalent than we see in the epidemiological studies currently. right now, the balance that we see in the US is that 40 million people in the US have episodic migraine. They have less than 15 headache days a month, and 2 to 4 million people in the US have chronic migraine. But I do think that number for chronic migraine is actually higher, because we may be asking the question incorrectly to patients when we're enrolling them in studies or seeing them in our clinics. And I've included a definition for medication overuse headache here, because many of the clinical trials that are specifically looking at migraine therapeutics have to include this definition and screen for medication overuse headache in order to have a more pure participant pool in the study. We often do not want to include participants in clinical trials who have medication overuse headache, because then that can confound our results ultimately in the final sample. And for our medication overuse criteria, these are people who have regular overuse for greater than 3 months of one or more drugs that can be taken for acute or symptomatic treatment of headache. And all of these people should be reporting 15 or more headache days a month. So in all of the people that we see for chronic migraine, they should be regularly screened for medication overuse headache also. And this is such an important population to exclude when we're looking at clinical trials. And in clinical practice, this is a really important population to identify to be able to cut out acute treatments and optimize preventive therapies, because it's very manageable and treatable. So here are some of the treatment goals that we really want out of not only our clinical practice, but also within migraine clinical trials. So for treatment goals for preventive treatments, we're really looking to cut down on the frequency, severity, and duration of attacks and improve response to acute treatment. And we want to one of the biggest things for patient preference is to reduce the overall disability. And so many of the outcomes, the clinical trial outcomes we'll see today are looking to measure these specific things. And this is what we want to monitor in our clinical practices as well. As far as acute migraine treatments go, our aim is really to resolve migraine pain and the associated symptoms. So our nausea, vomiting, photophobia, and phonophobia when an attack occurs, and try to get the patients back to a normal level of functioning as soon as possible. So why are these definitions actually important to us? Why do these make a big difference? I would say that having a standardized system to diagnosing patients improves education among our medical colleagues. Because one common thing we see is misdiagnosis. And so having a fixed definition for each headache disorder really increases the chance of reaching an accurate diagnosis. And having an accurate definition really helps us to specify the treatments that work for that particular condition. Standardizing outcomes in particular is important to clinical trials so that we can compare apples to apples when we're looking at preventive therapies and seeing is one preventive therapy, is their benchmark of overall reduction in headache days the same as its competitor? And so standardizing the outcomes and those benchmarks really help us to compare apples to apples rather than oranges to oranges. And I think it's very important to differentiate the outcomes that we have for preventive treatment compared to acute treatment, and even non-medication approaches, which are not commonly talked about, such as devices, nutraceuticals, and behavioral approaches such as biofeedback and relaxation and cognitive behavioral therapy. I think that standardizing the outcomes across the board, not just with pharmaceuticals, is of utmost importance. Because if we expect our non-medication options to work similarly to mainstream medicine, then we have to be looking at similar outcomes in clinical trials. One example of non-medication options using similar outcomes are the devices, the migraine devices. We have about 5 FDA-cleared migraine devices for acute treatment and preventive treatment, either or in some cases. And in each of the clinical trials, the devices were compared to sham devices, and they did use the same endpoints in many of the migraine medication trials that we used. So that's really nice that we're starting to see more of that standardization with outcomes in clinical trials. Yeah, and with research considerations, what do we need to know about primary outcomes? That's the next thing. So we haven't, the standardization of outcomes has changed dramatically in the last 10 years or so, pretty significantly. And one of the interesting developments that has come up in 2015 is the development of BEST. Now, this is a partnership between the National Institute of Health, the NIH, and the FDA to start to standardize definitions for specific disease states, and also to standardize biomarkers across different disease states. So this is a really nice book that's periodically updated, that really looks at specific definitions for different disease states that should be used in research considerations for the most part. And so really using this resource has been helpful for putting together different clinical trials for different disease states and the treatments to go with those. And so this is a really nice reference to consider if you're going to be putting together a research trial for a specific disease state. So that brings us to the prevention of migraine. During today's talk, we'll separate prevention and acute treatment because they're treated completely differently in migraine with different goals, different outcome measures, and they're studied completely differently. And the treatments, of course, completely differ as well. I thought that we could start off here by reviewing this consensus statement that came from the American Headache Society, actually at the peak of COVID. It was in 2020, I believe. This consensus statement came out from the American Headache Society about how to integrate newer migraine treatments into clinical practice. And this was by Dr. Ailani and colleagues. And this is the article that I often reference when I'm initiating preventive therapies for my patients or layering different preventive therapies. This table summarizes the medications that have proven efficacy for the prevention of migraine. There is one missing here that I can identify, which is atogepant, which received FDA approval for the prevention of migraine after this guideline came out. And I will say the other thing that's not added here is rimegepant receiving FDA approval for the prevention of migraine. Both of these medications are oral CGRP receptor antagonists that are a tablet that are used for the prevention of migraine. Rimegepant is taken every other day and atogepant is taken daily. So those are the only two that are missing here. Apart from those two, we have our standard blood pressure medications, seizure medications with divalproex and topiramate. And we have our antidepressants, which most commonly used are tricyclic antidepressants and our serotonin norepinephrine reuptake inhibitors. We have our injectable CGRP monoclonal antibodies and our infusion. The three are auto-injectors: irenumab, frenemezumab, and galcanezumab, and eptinezumab is our infusion that's administered quarterly. And our standard onabotulinum toxin, which has been FDA approved for the prevention of chronic migraine since 2010. The other thing, we do differentiate here preventive treatments between chronic migraine and episodic migraine. And the last thing I'll highlight here is that onabotulinum toxin A and atogepant was recently FDA approved specifically for the prevention of chronic migraine. So, identifying those patients that may benefit from treatment may be very helpful. And so these are just some of the factors that help with the optimal selection of preventive treatment. In my practice, I try to gauge what would be most tolerable for the patient based on other treatments they may be taking, their lifestyle, and really what the patient preference is in many cases. That's a huge factor for deciding on preventive treatment. And then, of course, in the U.S., we're kind of have to look at the cost and insurance coverage of each individual treatment when making these considerations too, in addition to the patient's individual medical comorbidities. And so let's talk a little bit about clinical outcomes. There is not too much out there in the literature about patient-reported outcomes for migraine. But there are a couple of articles that are systematic reviews that start to describe outcomes and endpoints for preventive migraine therapies. This first one that was released, it was actually just came out in 2021, specifically looked at endpoints for preventive treatment. So in this particular systematic review, they looked at around 268 publications and looked at the various outcomes that were looked at for preventive therapies. And I'll just highlight here that the most common ones that we tend to see currently when we're looking at migraine treatment trials is the change from baseline in monthly migraine days. In many of the studies that have been done recently, especially for CGRP monoclonal antibodies, and with the GPANs, namely rimegepant and atogepant, we looked at the reduction in monthly migraine days over a 12-week period. And in these trials, the baseline number of migraine days, we really wanted to see how much of a reduction in baseline over each individual month in that 12-week block, and also overall those 12 weeks, what the average reduction in those monthly migraine days was. In many of the recent studies, we also looked at a greater than or equal to 50% reduction in monthly migraine frequency, a greater than or equal to 75% reduction in monthly migraine frequency, and an average of a 100% reduction in monthly migraine frequency. And so I think I can safely say that for the past 5 years, most of the studies have included these exact outcomes very uniformly. It's been very good that a lot of the newer treatments have used this fixed outcome in their studies specifically. The other thing that I found really interesting looking at this study is that not all the studies looked at migraine specifically as the outcome in the outcome measure, but they also looked at just generally a headache-focused outcome. And so I thought that was very interesting. If we're studying a specific treatment for migraine specifically, it's interesting to make sure to pin down that specific definition and diagnosis during the screening period. And a little bit more about this systematic review. We found that more specifically, around 69% of the publications looked at greater than or equal to one migraine-specific outcome, and around 40% examined greater than or equal to one headache-specific outcome. About 50 to 51% of studies looked at acute or medication use, rescue medication use outcomes. Did these participants, did they cut down on their overall use of acute medication with the preventive therapy? And we looked at 40% of the studies looked at reported outcome measures, such as our disability assessments. And we're going to talk a little bit about those different surveys that are used in preventive migraine trials specifically. But the big thing to really draw from this systematic review of 268 articles is that the outcomes varied very significantly. So I promised you a couple of different assessments. So for patient reported outcomes in preventive migraine trials, patients are typically given a disability assessment during the study. And over the course of most of these studies, which are around 12 weeks, we give them one or two or more disability assessments to see if they're able to improve their disability with the preventive therapies. Classically, we use the Migraine Disability Assessment Test, which is the MIDAS assessment. And these are some of the specific questions that are asked to patients. And we're able to tally a point system here to get their score. And one of the questions is, just as an example, how many days in the last 3 months did you miss work or school because of your headaches? Or for example, on how many days in the last 3 months did you have a headache? And so based on the patient's number, we can tell here which grade they have, 1, 2, 3, or 4. Do they have little or no disability? Do they have 0 to 5 points? And as we go up here, if somebody has more than 21 points, they have severe disability. MIDAS is, I would have to say, one of the more common disability assessments that's used in clinical practice. When I ask people at the meetings which disability assessment they use in headache clinics, the MIDAS is probably the more user-friendly survey that's used for patients to monitor their disability. We also have the headache impact test, which is the HIT6. And this is just another 6-question assessment that's used. For example, when you have headaches, how often is the pain severe? And in this questionnaire, the more points you have, the higher your disability is as well. So with the MIDAS and the HIT6 assessments, the larger number of points you have, the higher disability you have. Whereas, so these are definitely 2 assessments used in clinical practice. More recently in research studies, the migraine-specific quality of life questionnaire is the more common assessment, validated assessment that's been used. Specifically, this is the migraine-specific quality of life questionnaire goes from 0 to 100. Basically, the higher number of points you have, the less disabled you are. A 0 basically means that you're completely non-functional, and 100 means that you're fully functional. So opposite from the MIDAS and the HIT6 point-wise. But in the more recent calcitonin gene-related peptide studies, namely the monoclonal antibodies, the migraine-specific quality of life questionnaire was used to see if patients gained points with their treatment over that 12-week period in the clinical trial. And so the more points that patients were able to gain, the more functionality they gained. And so, these are validated questionnaires classically in research, and certainly have different roles in clinical practice and different roles in our randomized placebo-controlled trials. So that brings us to acute treatments here. The same author, this is the same article that I showed you earlier. This is the consensus statement that was released that they included preventive therapies in the article and acute therapies, and they briefly touched on devices that are FDA cleared for migraine, and they also touched briefly on behavioral approaches and other non-medication approaches. So here are the acute treatments that have shown evidence of efficacy in migraine. We know that the treatments with established efficacy are our triptans. We have 7 of them available in the US of varying half-lives. We have 2 that are of a longer half-life, naratriptan and frovatriptan, and the other 5 are which have a shorter half-life. We have our ergotamine derivatives, our gepants. From an acute treatment standpoint, the 2 that are FDA approved are rimegepant and ubrogepant. We have lasmiditan, which is our first 5-HT1F serotonin agonist acute treatment. And then we have our classic NSAIDs, which are regularly used as well. And so this is a different systematic review that really looked at the outcomes and endpoints in acute migraine clinical trials. And many of the endpoints that we're going to discuss here also have become more uniform since 2018, since the FDA has changed the rules a little bit with measuring endpoints in acute migraine treatment trials, and we'll talk about those. And so prior to 2018, the big primary outcome from acute migraine treatment trials was pain relief. And so we'll see here that the majority of they included about 451 studies in this systematic review. The vast majority, certainly looked at pain relief. As of 2018, the primary outcome that's required for migraine acute treatment trials is pain freedom at the 2-hour mark. And so we see that number coming up here as kind of the second outcome that's more commonly measured now. There's also rescue medication use after the initial acute medication that's been studied has been used. What other rescue medications were needed within that 24-hour mark after that the study drug was used? We also look quite commonly now at secondary endpoints that include headache recurrence within 24 hours and 48 hours. And we also look at the absence of associated migraine symptoms very commonly as a secondary endpoint now. The absence of the most bothersome symptom, for example, such as nausea, vomiting, photophobia, and phonophobia. Classically, we looked at all of the associated symptoms, but more commonly nowadays, we're looking at the most bothersome symptom. And of course, we're looking at disability and impairment in this population as well. In acute treatment trials, the big question is always how quickly were patients able to return to their regular functioning? Was it with no disability? Is it the 2-hour mark, the 4-hour mark, the 8-hour mark, the 24-hour mark? Those hourly marks to return to functioning are the biggest benchmark that we've used more recently in acute migraine treatment trials. So we have our acute treatment benchmarks here. Of the 450 or so articles that were included in the systematic review, 72% looked at pain relief, 65% looked at that pain freedom at 2 hours. Freedom or relief from migraine-associated symptoms was around 66%. Use of acute rescue medications was around 65%, and disability that was measured in around 41%. But I will say also in this study, we saw a variety of endpoints, and not everybody had the same secondary endpoints in particular. Even though they had, for example, pain freedom at 2 hours as the primary endpoint, the secondary endpoints certainly varied from study to study for these acute migraine treatment trials. And here's an example of one of the validated questionnaires that is specifically for acute treatment of migraine. This is called the Migraine Treatment Optimization Questionnaire. This is a shortened version with just about 5 questions that can be used to gauge if an acute treatment is working optimally in a clinical trial or even in clinical practice. Are you able to return to your activities quickly? Can you count on your migraine medication to relieve your pain within 2 hours for most attacks? Is it well tolerated? So these are some of the common questions that I ask in clinical practice as well. This is a validated questionnaire. And so what about our clinical considerations? This was an interesting study that was done in Europe with over 1,000 patients surveyed. This was a retrospective chart review. They looked at people who basically got these varied diagnoses of headache, general headache in 64%, migraine in 28%, cervical pain 4%, sinusitis in 1%. And they found that the vast majority of these people actually had migraine, despite getting all of these other diagnoses. And we found that only 35% of specialists, 51 of which 51% were neurologists, actually diagnosed patients correctly with migraine. And so coming to an accurate diagnosis and having standardized definitions is so important so that we're diagnosing and treating correctly. And what about patient preference? This is a really interesting qualitative study that came out last year that looked at what the patient wants. And in the with these patients, we have about 459 patients that were looked at in this study and 21 publications. The 8 themes that patients want out of an encounter with their provider for migraine is shared decision-making, a tailored approach. They want to be able to trust their healthcare professional. They want to hear about a diversity of treatment options that are non-medication and medication. They want some holistic approaches in addition to mainstream medications. They want to be able to understand complex treatments. They don't want to be undermined, or the patriarchal approach to treating patients is not preferred by patients. And they want to have mutual respect between the patient and the provider. While, I mean, a lot of these seem very obvious, I think it's really hard when in talking to patients for them to get all of these 8 things out of an encounter. It's very difficult to make a partnership that works, a professional and respectful partnership where the patient feels comfortable asking questions and sharing ideas effectively. Patients, this is really interesting. In this study, they actually preferred non-pharmacological approaches. They wanted their treatments to have high effectiveness, work fast, have a long-lasting effect, be cost-efficient, be easily accessible, and they wanted to be able to manage, give themselves the treatment so that they can really have autonomy over those treatments. And they had a mixed preference for preventive treatments and as-needed treatments. And as far as outcomes, patient-reported outcomes goes in this study, the patient goals for outcomes were improving function, avoiding side effects, not getting addicted to their treatments, not having recurrence of the pain, and avoiding their migraine-associated symptoms, so that nausea, vomiting, sensitivity to light, and sensitivity to sound. So in summary, we looked at a lot of different definitions today. We looked at patient-reported outcomes from 3 different perspectives. We looked at this data from a clinical perspective for when we encounter patients in our practices. We looked at it from a research clinical trial perspective, and we looked at it from a patient perspective. And so I hope that this was helpful, and I would love to take any questions that you have for me now.
Dr. Kuruvilla, thank you very much. This has been a really great introduction to PROMs and how we can utilize them in practice and in clinical trials. I have a few questions for you. The first one I have is around ICHD and using ICHD criteria. And you said that you explain this to patients and you show them these criteria. And I think this is a great idea, because we do have some resistance from some of our patients where they say, well, that's not what I have. That's not what my doctor told me. And we don't have it in the family. We don't have anybody with migraine, so I can't have it. So it's great that we have that. My question is around ICHD-3 is the latest, but we have ICHD-1, ICHD-2, ICHD-3.
Yes.
How does this affect clinical trials, and how using these different versions of the diagnostic criteria? How has this affected clinical trials?
That's a great question. As far as I know, the big updates over time have been for chronic migraine and for medication overuse headache. And so earlier on, we've had less. I've noticed that there's more research now, that there's been more light shed on chronic migraine over the past decade. Prior to a decade ago, we had less research, less indications, and less clinical trials specifically for chronic migraine. And so I do think that those updates that were made to ICHD3 really help to multiply the clinical research trials that we have for that specific disease state. But apart from that, generally, a lot of the definitions are very similar that between ICHD 1, 2, and 3.
It hasn't affected the main types of migraine, right? Or
Right.
headache. Like if we talk about
Correct.
tension type headache, migraine, they haven't really changed a lot. So does
Right.
that mean that clinical trials done 15 years ago, they use the same criteria for enrollment of patients?
Not necessarily. In looking back at some of these systematic reviews, if we go back more than 10 to 15 years ago, actually, people were not using accurate definitions for migraine. They were just using a general term of headache and not and requiring that patients maybe have one migraine associated symptom, nausea or photophobia or phonophobia, but not sticking to the strict guidelines that we follow today. So I think over the past 10 years, even since ICHD3 that came out in 2013, that's a requirement now to stick to that diagnosis.
And the other thing that has changed, and correct me if I'm wrong, is that enrolled patients in clinical trials today have to reflect reality in terms of the actual prevalence. You showed us that there's a tendency for this condition to affect more women than men. And that
Yes.
means that we, in the previous clinical trials, did not actually account for this. And that means that the older studies did not really reflect how people in real world would respond to medications. Am I right to
Yeah,
say that?
I think that even though we know that migraine predominantly affects women, the clinical trials have also classically contained about 80% of women. So the gender-wise, it has been reflective of the general population. But I do agree with you that there's one component, which is race, that has not been consistently reflective of the general population. Classically, our clinical trials for migraine have been mostly 60 to 70% Caucasian. And so now we actually have initiatives built in and requirements from the FDA to include a certain percentage of a breakdown of many races. So I think that's been the biggest change, I would say, over the last 5 years, to have a larger representation of the population, because we do, I mean, in the United States and all over the world, we have such a diverse population.
Absolutely. The second question I have is around the tools that you mentioned. You talked about the Midas and you talked about the HIT6, and how are using different scales affecting your ability or the ability of a practitioner to measure or to actually line up medications against each other. If in one trial they use the HIT6 for quality of life, and the other is Midas, how can a practitioner interpret data and see how to choose which medication?
Yeah, it's very difficult to do because we're not comparing apples to apples. And with, for example, the migraine specific quality of life, a higher number is good, whereas with HIT6 and Midas, a lower number is good, right? And so it's really difficult to compare those validated questionnaires. But I suppose we can see generally, based on the number of points, how what level of disability the patient was able to recover from, or how much better they're able to function. But there's really no way to compare them directly to each other.
Okay. I do have a few questions from some of our followers today or our audience today. There's one around sensitivity and specificity of ICHD3 for migraine. I'm not sure if I wouldn't know the answer from the top of my mind. I don't know about you. How specific and how sensitive is it? Migraine.
So it's really interesting. We do have a validated 3-question questionnaire. I mean, we know that, for example, photosensitivity, nausea, and disability, those 3 factors have a sensitivity of about 90 to 94%. And so we know that those 3 specific factors have that that sensitivity and specificity, but ICHD3 as a whole, I'm not able to give a specific number about specificity and sensitivity.
It's the same. I did study that, but
Yeah.
sorry for the for the person who did ask this question. I think you can go back to the literature and you will be able to find this the answer to this. You talked about changes in also you talked about patient-reported outcomes versus clinical trials and what the patients want. How are apps that exist today affecting research, and how are we able to utilize today the data that's coming out of some of the apps? Some of the apps have a database of 3 million patients around the world. Are we able to utilize this data?
Yes, specifically the one app that's done an interesting job of getting detailed data. The app has been validated in the literature, and probably has the largest database is the Curator app, which is available and many patients enjoy because it's very detailed and gets a large amount of data. That's the only app that I know of that studies have really been able to pull data from and publish data. Really interestingly, a lot of the devices now, the Nerivio device and the Cephaly device, just as an example, have their own headache apps with the device, and the Nerivio device in particular has published multiple studies pulling data from just their individual app. It's a homegrown app that has so much detail to it and includes non-medication treatments such as relaxation techniques with the app. And so they're the one app that's associated with the treatment, the Nerivio device, that's taken it to the next level and had several publications come out of it.
And do you think that this is coming to medications as well? We haven't seen this with any of the new medications. Do you feel that this is going to be adopted by others? I hope, but you possibly have better.
Yeah, I hope so too. I know that some of the newer treatments developed considered making specific apps in order to not only help the patient-provider relationship, but also get research out of it, but they haven't really gone anywhere, the ones that have been proposed for medications. I don't know why that is. Is it that the Nerivio device, you need a cell phone to be able to use the device and control it through their app? And so it's very intuitive to have an app along with that. With a lot of the medications, patients, I wonder if one complaint that we hear from patients is they don't want to take an extra step to register online separately or download a separate app. And so it might not be in the best interest of pharmaceutical companies, but I haven't heard of any medications that have done the same thing so far.
Thank you very much. It's been a pleasure having you with us tonight. Thank you for your great presentation and for your presence. And we hope to see you again on the IVPN Neuropsychiatry and Association of Migraine Disorders Masterclass. Thank you very much. Have a very, very good day.
Thank you. Thank you so much for having me.
Well, just a quick reminder, if you have any questions for our next speaker, you can type them in the question and answer section of this presentation. It gives me great pleasure to next introduce to you Dr. Vittorio Iantorno. Have I said it right, Dr. Vittorio? You're on mute. I will do a quick, you're still muted, but I'm going to do a quick introduction. Dr. Vittorio is joining us tonight from Dubai. He is a consultant neurologist with more than 20 years of European experience in the field of neurology. He completed his studies in Rome, Italy, obtaining his medical degree in medicine and surgery, and then qualifying as Italian board in the Italian Board of Neurology. In 2001, Dr. Iantorno moved to the UK, where he was the clinical lead in neurology and head of neurology department in one of the largest foundation trusts in the United Kingdom, the Heart of England NHS Trust. He is also, at the time, he also acted as the chairperson of the local Parkinson's disease operational group. Dr. Iantorno worked in various NHS hospitals in the UK, including East Kent NHS Trust and King's College Hospital in London, Royal Free Hospital in London, and Hertfordshire NHS Trust, before moving for over a decade to Heart of England NHS Trust. And then in 2015, Dr. Iantorno moved to Dubai, where he brought with him, of course, the many years of experience that he has in private and in public hospitals in the UK. Dr. Iantorno's clinical trial skills have always been regarded by peer colleagues and all patients of being of very high standards in the management of neurological diseases, assessing, investigating, and treating neurological patients presenting with a whole spectrum of acute and chronic neurological conditions. And of course, migraine is one of these. Dr. Iantorno believes in patient-centered care, focusing on patient and individual and on the individual's particular healthcare needs. The goal is to empower patients to become more active and to have the power to participate in their care and not only to treat the disease. He does offer a holistic approach to patients who live with different neurological conditions. I'm not sure if Dr. Iantorno is still on the line. In the meanwhile, I do have some, I'm not sure if we have an issue with the connection for Dr. Iantorno. I have a few questions that came and they were not really towards the first presentation, but I'm able to answer these. Migraine, is it permanently cured? I think is the question from Abdul Wakil. No, there is no cure for migraine. You can manage the symptoms, but today we do not have cures. We have medications that control the symptoms, that are enabling the patient to live a better quality of life, but there is no cure for migraine. There's nothing that you can give and then live happily after without the condition. The condition itself has a nature that means that it changes throughout different cycles in life, and sometimes when patients go through different stages in their life, there is a change in the frequency and the severity and the way that the patients live with a condition. I had another question that was around, I think I'm going to just go back to how long, I think Usman was asking how long is a migraine attack lasting, and migraine, according to the ICHD-3 criteria, lasts from 4 hours to 72 hours. So from 4 hours to 3 days is one attack. Longer than this, it becomes a different kind, but the general migraine definition is 4 to 72 hours. And then I think there was another question around migraine and trigeminal neuralgia. How are they connected? There are different conditions, and you can go back to the ICHD3 and look at this. It's available online, and it is something that is very well accessible, and you can find this information by just going to the ICHD3 website and look at the different criteria for both of them. They're different conditions. Okay, so can we see Dr. Vittorio if he's back? Just give me a second.
So it seems, Hiba, that Dr.
Yes.
Hiba, that Dr. Vittorio has a connection problem.
He's
And
back.
we are,
I can see him.
he's
Can you
back
hear me?
now.
Yes, we can see
yes,
you.
Doctor.
I'm
Sorry.
sorry, and then apology for the inconvenience. Apology for having lost a few minutes. But,
No problem. I did answer
let's
some
go
questions.
back. Let's go back to where we were.
Okay, so I have done your introduction and I have answered some questions that were in the chat, and we're ready for your presentation. You're going to be telling us today, or you're going to be sharing with us today, the unmet needs in management of migraine, whether in acute or preventive options.
Absolutely.
Perfect. So
Can I have my presentation back on the screen, please?
You can go ahead and show your slides, Doctor.
Okay. Again, thank you so much. Can you hear me now?
Yes, we can hear you loud and clear.
Anyway, thank you so much, everybody. Thank you, IVPN. Thank you, Pfizer. Thank you, the organizer, for this wonderful event, educational evening event on all social platforms. It's my pleasure being here. My name is Vittorio Iantorno. I'm the consultant and lead neurology and director of Neuroscience Institute in King's College Hospital, London, in Dubai. I've been given the pleasure and the topic of talking to you about what are new or real development in prevention and treatment of acute and chronic migraine. And my topic is the unmet needs in the treatment and prevention of migraine. So migraine, as the previous speaker talked about, is a very disabling disease. Is as a big social burden, economically, socially, and it's something that has not been resourced as it should have been done.
Dr. Vittorio, can we go for full screen, please, for your presentation? I'm sorry to interrupt. Perfect. Thank you very much. Sorry for the interruption.
So, as I was saying, it's according to the American Migraine Prevalence and Prevention is one of the most debilitating disease. And if we look at the data, it's a more grievous, let's say, social disease than epilepsy, diabetes, and asthma combined. So, what do we offer patients, or what do patients expect from doctors? Well, they expect to be treated for acute event or chronic event in a way where there is full resolution, medications are easy to take, and full efficacy with a safety profile of a high standard. Now, there are various unmet needs, considering what we had so far regarding the traditional acute treatments. And one of the main topics was about tolerability issues. In fact, we saw from data that up to nearly half of the patients experienced adverse reaction within the first 24 hours of taking them, up to an astonishing percentage between 60 and 80% of patients experienced return of pain within the 24 hours. This is not what they are looking for, or what we are looking for as doctors treating such patients. The more acute medications the patients take or were taking led to poor response, adverse reaction, but what we call overuse analgesic headaches due to many traditional acute therapies taken by patients. In the 90s and until a few years ago, it was customed and usual practice to treat patients with acute attacks with triptans. But triptans were good medications, but carried some contraindications, especially in patients with vascular risk factors. And as you can see from the slide, the statistics tell us that there are more than 2.5 million people in the US with such pathologies. So what we can offer now, or what patients want from a treatment for acute and chronic migraines, they want something which is easy to take, something that fits it all. So one medication that is able to treat both the acute and the chronic migraine. So something that is called only dual therapy. So over the past few years, we had several medication targeting the CGRP, the calcitonin gene related peptide. And one of these medications that can fit it all is rimegepant or Nurtec, which is indicated in the adults for both acute treatment of migraine with or without aura, also considering the safety profile with especially regards to cardiovascular disease, or can be used as preventative treatment of episodic migraine. Episodic migraine are those migraine that are classified occurring between 4 or less than 15 times per month, compared to chronic migraine, which is 15 plus. Now, there have been several phase 3 trials to test the efficacy and tolerability of rimegepant. And these studies have been tested, of course, versus placebo, and both for acute treatment of migraine with or without aura in adults. So it's a fantastic option for acute migraine. And in the eligibility criteria, of course, have been included patients, adult patients, so above 18 years old, more than a year history of migraine with or without aura, onset before the age of 50, and episodic in the episodic group of migraine. So those migraine which occur less than 15 days per month within the past 3 months. So both migraine or non-migraine headaches. So rimegepant 75 milligrams have been tested against placebo. The total number of patients tested was in around 700-800, and it was tested also to treat the single migraine attack of moderate severe pain, which were the endpoints where basically the primary efficacy, so given freedom from pain at 2 hours post-dose, or freedom from the most bothering symptoms that migraine can bring, always at 2 hours post-dose. There were several secondary endpoints, and these endpoints were divided and classified in early action, which means less than between 1 hour and 1 hour and a half. And one of the main things was the consistency of given freedom of pain of the most bothering symptoms up to 24 or 48 hours, including also safety and tolerability of the medication. So the study then told us that rimegepant met both its co-primary endpoints, and these were a significantly greater proportion of patients with freedom of pain at 2 hours and the most bothering symptoms at 2 hours post-dose versus placebo. The This study that I'm showing you here, the study 303, met 19 of the 21 secondary endpoints that were divided into the categories that I've just mentioned. And rimegepant met all the 3 endpoints, especially the one which gave freedom of pain up to 48 hours, so 2 days with great efficacy, up to 1 hour from taking the medication. So how did we test this, the efficacy of rimegepant? The efficacy was based on also previous triptan response. So there were triptan naive patients treated with the rimegepant. The rimegepant was tested in also patients with currently were taking the triptans, history of treatment failure with one triptan, or triptan failure, a treatment failure using more than 2 triptans. And the results concluded that rimegepant were very effective compared to this four group of patients, and currently is being investigated in phase 4 studies, so nearly more than 400, study number 406, for its use in acute treatment in adults in migraine with or without aura. So it was a safe medication, or it is a safe medication to use? Yes, the rimegepant was versus placebo, where the most common side effects were nausea, dizziness, or urinary tract infection, but these adverse events were related to the treatment. Rimegepant, the side effects compared to placebo were very similar, and there were really no serious adverse events reported. So safety is and was of a very high level. Now, what are the current acute treatment, the unmet needs for acute treatment in migraine? The data shows us that up to 81.5% of patients dropped or were not responding in acute treatment with triptans, and these were due to 40% adverse events. More than 30% dropped out from taking medications because of lack of response. So the 2019 American Headache Society addressed these unmet needs in migraine and recommended to consider novel acute treatment in patients with especially with a contraindication to triptans use, or those patients who fail to 1 or 2 oral triptans. One of the points that was addressed in the previous by the previous speaker was the medication overuse headaches. This is a very well recognized entity and affects up to 60-70 million people worldwide, and is considered to be a burden not only socially but also economically. So something that it has to be taken into account when we plan the care of our patients, both for acute or chronic treatment of migraine. Again, this the risk of going to medication overuse headaches is huge, because tend to cause on a long run chronic migraines in patients who start having few migraines here and that. And over 70% of patients with chronic migraine were in fact overusing acute care medications. And there is a study in the American Migraine Prevalence and Prevention, where there was a study for more than 200,000 patients, told us that up to 50% of patients never consulted the doctor or self-medicated themselves, so with a high chance of getting into the overuse medication headaches. Now, Nurtec, rimegepant, is effective and has got great clinical value as treating both acute and chronic migraine. This medication belongs to the family of calcitonin gene-related peptide. How these few molecules, little protein, is important in migraine? It's important because it's involved in the pathogenesis of migraine itself. So in the vasodilation, in the neuroinflammation, and in the sensitization pathway leading to migraine. And rimegepant, Nurtec, was very effective in either blocking the neurogenic vasodilation, in halting the cascade of inflammation, and inhibiting the central delay of exaggerating pain signal from the trigeminal nerve to the caudal trigeminal nucleus. So it's why then it was brought forward, and the FDA then approved rimegepant for both acute and prevention for migraine. So the beauty of Nurtec compared to the triptans is that it can be used in any type of migraine, acute and chronic. There is no contraindication in any set specific group of patients, so those with cerebrovascular disease. And it's a rapidly dissolving formulation, and it's very effective because the peak concentration is rapid, half-life is about 11 hours, and sustained benefits from a single dose is up to 48 hours. Again, this is a summary of the efficacy and the beauty of the medication. Rimegepant has got a quick action up in the first even 60 minutes, and is sustained benefits up to 48 hours, so 2 days. And in fact, the statistics, the studies tell us that up to 65% of patients taking Nurtec, oral dispersible tablets, is more effective than the patients taking placebo. Do we need to consider this for all patients? Of course, each medication, each plan of care has to be tailored to the patient's need. But we need to have on the table all the tools to decide which one is the best indicated. And of course, what do patients want from treating migraine? In any case, from acute or chronic migraine, they want quick resolution, some medication or something which is easy to take, something that is easily administered, and something that has not to be taken many times a day to achieve benefits. So in this context, in this picture, Nurtec is something that we need to consider because of the quick action, safety profile. There is no real contraindication apart from pregnancy and lactation, and it's a formulation that is easy to take. Now, we said at the beginning that migraine has got a huge and carry a huge social burden, especially socially and economically. And studies with the rimegepant have shown what we call societal benefits with the reduction in absenteeism, so people going to work, or presenteeism, so people who were going to work but had no such their days were not such productive as they should have been. So the data are there in my slides. So acute treatment with Nurtec confers significant improvements both to what I said, not going to work, or going to work and being productive. Why we had the triptans around for 20-25 years, and now the rimegepant and Nurtec came on the market. What's the difference between the two? The difference are substantial. I've highlighted the main bullet points in this slide, where up to nearly 40-50% of patients taking triptans require a second dose after 2 hours. On the contrary, rimegepant and Nurtec had an early action in the first hour and sustained benefits up to 2 hours effect with pain freedom or freedom from the most bothering symptoms of migraine, and sustained benefits both for pain and the most bothering symptoms up to 24 and 48 hours. And the side effects, again, compared to placebo, were quite similar. As you can see also from this slide, in Nurtec, the onset of pain relief were as early as 15 minutes in some patients, but very significant in the first 60 minutes. And this is what we want as doctors to provide patients with. And this is what patients want from us, something which is highly effective, well tolerated, easy to take, and great efficacy. Half-life is something else that we need to consider when we prescribe medication, especially in women, because the ratio of women, female-male in migraine, as we all know, is 3:1 or 4:1, and especially the group age is women of childbearing age. So what patients want not to take medications very often, and Nurtec offers such treatment for more migraine, because compared to other similar medication available, as you can see, patients treated with Nurtec had an average of only 1 pill per migraine attack, and only basically the idea is for them to take one every 48 hours. So not many tablets on a monthly basis if we go for treating chronic migraine compared to something similar available. So the other question was, this small molecule of calcitonin G-related peptide receptor antibodies are effective if taken with other similar molecule? Well, I guess more probably studies, more further studies are required, because the conclusion of this is quite unknown. Nurtec, again, it's a great medication, offer great benefits within even within the first 50 minutes, but certainly within the first 60 minutes, and provides sustained benefits at 24 hours or 48 hours. So something to consider, and something to consider also in view of the safety profile. Now, what have been so far the factors driving the choice for treating not only acute migraine, but preventing migraines to occur? Well, one of the things was the efficacy, the sustainability, and the safety profile. As you have seen from the previous presentation, the armamentarium of medications we had so far was huge, spanning from beta blockers, antidepressants, antiepileptics. So if we've got an armamentarium of so much medications available, in reality, what tells us that no one works as it should be effectively. So now the reality is we have got a new way, a new model, a new armamentarium to use for our patients. And CGRP are the present and the future of treating such patients. Again, the current preventive therapies have got some limitations in everything, and are mainly the side effects can be massive, can be interfering with day-to-day life, and can also cause not only psychological problems from anxiety and depression, which migraines can cause anyway, but cognitive issues, and the fact that the efficacy of them is not great, side effects profile is not so safe, and the dropping out of patients without telling the doctor using standard of care has been one of the reasons why we looked at a different direction, and thank God CGRP came on board. Now, do the patients prefer a specific way of a specific modality of receiving medications? Well, majority of patients prefer oral medications versus injections. And this has been the case also considering different CGRP antagonists in this scenario of treating acute and chronic migraine. Now, as I said before, Nurtec is indicated for adults, and as I said before, there are also different anti-CGRP, which majority of them come in the form of injections. So a meta-analysis can compare oral anti-CGRP with injection. So basically rimegepant versus Aimovig or Emgality. And the change from baseline monthly migraine days at 3 months, there were no significant difference between both Aimovig and Emgality versus rimegepant. So we safely and confidently can say that Nurtec had a clinical value in the way we treat both acute and chronic migraine. And it's something we need to consider in especially female patients, because the half-life, if you can see from this slide, of course, apart from being one of the main cause of disabilities in young people, but the half-life of rimegepant compared to other anti-CGRP biologics is 11 hours versus 1 month. And this has to be also discussed with women of childbearing age suffering from migraines in view of potential events of pregnancy. So again, what do patients prefer is something that we need to ask and engage. And considering that the efficacy of anti-CGRP, many patients prefer oral medications versus injection. But we have got Nurtec, which is a very good choice in the way we manage patients with migraines. And again, I would like to highlight the safety profile. So the main problem with anti-CGRP is constipations, site injections, muscle cramps, but nothing affecting memory, nothing affecting weight, nothing affecting heart rhythm, and nothing causing vasoconstriction in selected group of patients. So rimegepant is then not contraindicated in such patients, unlikely anti-CGRP monoclonal antibodies. And the gepants are non-immunogenic agents, unlikely other anti-CGRP monoclonal antibody associated with potentially immunogenic problems. Now, as we said before, what do the patients prefer? They prefer something which is effective and is not taken quite often. And rimegepant 75 milligrams comes into the picture because its safety profile and its efficacy up to 48 hours is taken every other day, and is such a convenient oral medication with dual benefits. Dual benefits because it can be used in any circumstance, acute and chronic. It doesn't require any injection, and hence there are no associated injection site reactions. Again, this is just a repetition of what I said. The efficacy, sustainability, not only up to the pain freedom at 2 hours, but the efficacy of long-term treatment with such a medication, especially greater reduction in migraine frequency compared to placebo at 3 months. And even there is this long period of time of treating patients with rimegepant, there were no serious safety issues noted. And tolerability of the medication was absolutely similar to that of placebo. Now, that's the overview of my presentation. I think we have got a great opportunity here on many levels to change the way we treat successfully our patients. So I hope I gave you some useful take-home messages, and I'm really open to any questions you want to ask.
Thank you very much, Dr. Iantorno. I do have a few questions in our question and answer section, and to all our viewers tonight, if you do have any questions, please post them in the question and answer, and we'll try to get to your question before the end of the evening. The first one is CGRP. I mean, it's we are talking about in your presentation, there's a lot of talk about the CGRP. How is CGRP actually related to migraine?
Now, there have been several studies confirming that during a migraine attack, there are a high level of CGRP released into the system. And there have been also several studies confirming that, for instance, climbing high mountains and going through the hypoxic event there caused a high release of CGRP. So these anti-CGRP were tested in many of these scenarios and proved to be very effective. So the blocking that cascade where CGRP is implicated caused a resolution of the migraine attack. Basically, CGRP are implicated in the pathogenesis of migraine, both in the vasodilation, which is one of the cause of migraine, in the sensitization of the pain pathway, and in the inflammation starting from the trigeminal nerve. So these anti-CGRP molecules were there to block and sort the problem out. But the interesting thing is I had patients climbing high mountains, the Kilimanjaro, and they said, well, previously I had it with this new model of treating, my migraines settle completely. And there are several studies confirming this, confirming basically that the CGRP are hugely implicated in migraine. Hence, anti-CGRP is the way forward.
And we know that there's another substance that we've just started to see a new substance that's also implicated, and we might in the next few years see new medications that target a different peptide that might be related to migraine. But today, CGRP is the one that all these new medications is targeting.
Well, we changed the way in the past 20 years. So
absolutely.
So.
What is the difference between atogepant, ubrogepant, and rimegepant?
Well, there are medications that can be taken every 24 hours, and medications can be taken every 48 hours, and medications that can be taken once a month. Now, my personal view is always involve the patients in decision-making. It depends on the patient's profile, safety profile, on the patient's needs. Mm-hmm. So acute treatment is something, acute prevention is something else, but if there is something that can combine the two, much better.
And in your practice, do you start first as abortive with rimegepant? Do you start the patient with rimegepant, see how they respond to it as abortive, and then use it as preventive? Or do you start from the beginning and say, well, use it every other day if someone is disabled by their migraine? How do you manage this?
Well, it depends on clinical presentation, first of all. It depends on the patient's needs. So if we talk about a few attacks, so if we talk about the low aspect of episodic migraine, yes, one of the things is try the acute treatment, so a few tablets and see what happens. But if the number of attacks increase and there is a need for prevention, where the patients experience 7-10 attacks per month, then prevention is my preferred way forward.
I think it's one of the questions. There is a maximum of 18 tablets per month.
Correct. Correct.
So what in case more than 3 attacks happened in that month is the question from one of our viewers tonight. Would you go then to prevention? If you need more than 18, then it makes sense for us to go for prevention. How would you manage this?
I potentially may try more than 18 tablets per month, which probably will be my preferred option. But again, it depends on case by case. The maximum allowed is 18 tablets per month. So the one every 48 hours is there for a reason. But in specific case, it depends case by case. Or you can add something else to it.
And I have a question. I think you did answer this, but just so that if it wasn't very clear, can rimegepant be given as a rescue therapy in a patient already taking injectable CGRP monoclonal antibodies?
It can be tried, but more studies are needed because they are needed. But it can be tried. It can be tried. Can be combined with injection of the same family of treatment. And
then the next question is I also think is very interesting around how many cycles or how long do you use an anti-CGRP? For how long do you use it?
Now, that's a very good question, first of all. There are several studies confirming that we can use anti-CGRP on a longer run. There are some studies telling us that there are safety data for 5 years. My approach is start 3 months and reassess. That's what I normally do.
And it's what we used to do before. So if someone was on any of the classic, we would say every 3 months, reassess the patient, see. But if they're stable, do you leave them on the medication for longer than 3 months? Like if someone comes back after 3 months and they're doing well on the medication, do you continue to see them every 3 months, or how do you follow up on these patients?
Well, 2 questions. One is the anti-CGRP review every 3 months and decide, or every 6 months. The other one is the standard of care we had so far, using the prevention. In general, my philosophy is 6 months and review, whatever. Because I think it makes sense, assess efficacy, assess benefits, assess side effects, and making sure that the patient is safe. I give myself a 6 months period in general.
Okay, I have a question next on using lasmiditan versus rimegepant in acute attacks. How do you assess both options for your patients?
Unfortunately, I need to defer this question because I haven't got much experience on the first one.
Okay, so is it Revu in UAE? Revu, is it lasmiditan? Yeah. That's the one. Okay. I know that in North America, in the States, it is controlled because of the sedation that it does pose for patients. You cannot drive with it. And while this is not a case in...
It is not a control medication as such as control other medications in pain management. No. It's not. But in case there are, of course, side effects which involve alertness and affection on level of consciousness somehow, yes, of course, you ask the patient to stay and observe the patient 2, 3, 6 hours before releasing it. But it's not controlled here in UAE. Okay,
but it's the same. I think it's not used as much as the GPANs or
correct.
The
CGRPs
in North America as well, because of that, effect.
I think we share same data, Canada and UAE. Yes.
Yes. So the last question that I can see, or I can see actually a couple, medication overuse headache and rimegepant we know that there's we need usually to detoxify the patient to get the best result. Do you feel that with rimegepant you can start directly, or does rimegepant cause medication overuse headache? What is your experience?
Not in my experience. So first question is not, it does not cause overuse analgesic headaches. How do we treat the overuse analgesic headaches? It depends, because it can take up to 3-4 months to wean them off. And it's why we need to prevent this to occur both in acute and chronic setting. So it's why the specialist is the specialist.
And the second part is, do you feel that there is, or do you see in your practice that there's a difference between migraine with aura, efficacy in migraine with aura and migraine without aura with rimegepant? Do you feel that it works differently, or the success rate is different for your patients?
In my practice and in other colleagues' practice in the region is quite similar.
Perfect. Thank you very much. I think the last one is around migraine in pregnancy, how to manage acute attack and prophylaxis.
That's a problem. That's my answer. Again, there is no medication which is safe in pregnancy and in lactation. That's something that probably we need to look at for the future. The data are there to say don't use them. Unfortunately, is one of those conditions which is a burden to the patient, and we have not much at the moment to look at. But I hope that the future will be bright for such patients, because it's a quite large number of patients then coming to clinics wanting to expand the family or just expecting, and there is really nothing I can do. So hands are tied, and it's really a pity.
Do you, the FDA just cleared the use of ibuprofen in the first 2 trimesters, but not in the 3rd trimester. Do you use ibuprofen or acetaminophen or paracetamol? Do you use paracetamol as an abortive?
I don't use ibuprofen. I use paracetamol. I found quite effective magnesium.
Yes, magnesium as well is something
so,
that.
And that's it for now, really.
What about omega-3?
I haven't used it, but I found using magnesium quite effective, actually.
Okay, so in the US and Canada, we do talk about vitamin D3 and adding vitamin D in pregnancy or people planning to get pregnant. Omega-3 is seen, if from a good source, is also something that we do add to magnesium, but magnesium is the first alongside acetaminophen or paracetamol and ibuprofen only in the first 2 trimesters. And for preventive, I still see doctors using a beta blocker because of preventive.
That's as prevention of beta blockers are probably top of the list. But again, do we really know the long-term effect of it on the baby?
Again, it's the American, I think, Migraine Foundation did have a statement, or they did have some recommendations. All of this is benefit versus risk, possibly, and if the mother is in severe pain, is also not something that, and most of our patients in the first trimester, they might get worse, but most of them actually get better in the 2nd and 3rd trimester. So magnesium is a good idea. Relaxation, cognitive behavior, biofeedback are things that
the non-pharmacological treatment. I fully agree with that.
Yeah, I think we're almost at the end of this excellent presentation and question and answer session with Dr. Vittorio Iantorno. Thank you, Dr. Dina Corovilla. I think she has already left us to continue her day in the US. And I thank you very much for this wonderful presentation. I will leave you with a request to join us next month on another event, and hand over to Maya. Dr. Vittorio, we hope to see you again in one of our master classes. And I will
Thank you very much. It's been my pleasure being here tonight.
Thank you very much. Have a very good night, everybody. And I will leave the floor to Maya. She has a few announcements around events with the neuropsychiatry IVPN section. Thank you very much.
Thank you and good night.
Good night.
So, hello, everybody. Let me start by thanking our wonderful moderator, Dr. Hiba Bani. Thank you for being with us. And we are looking forward to see you again during our 6th migraine masterclass that is scheduled on June 23. So save your dates and stay tuned. We'll be discussing the adverse event of anti-CGRP and migraine prevention. So the preventative therapies in migraine. Save the date, and Dr. Hiba will be with us also to moderate our 6th migraine masterclass. So let me remind you that you will receive your certificate of attendance by email within one.
Maya, you are muted.
Sorry, excuse me. So I would like to remind you that you will receive your certificate of attendance within 1 week from today by email. And this webinar is CME accredited. It's 2 hours. And you will receive your certificate, as I mentioned, by email within 1 week. If you missed any part of this webinar or would like to visit any of these presentations, you can visit our IVPN library, where all the recordings of these sessions and other activities, educational activities, are posted in our IVPN library. So you can revisit the lecture there, and our library is available free of charge, currently available free of charge, so you can download the presentations from there. Finally, I would like to also encourage you to follow us on our social media platform, mainly on LinkedIn, in order to receive all the updates regarding our future educational activity. As I mentioned, we will have more migraine master classes, and our next one will be on June 23rd. Our next educational activity will be about multiple sclerosis on the World Multiple Sclerosis Day, which will be Wednesday, May 30. See you soon, and until I see you again, stay safe. Have a good night.